Welcome everybody, and thank you for coming today. That seems a bit surreal. So I'd like to introduce myself first and the other guests that we've got that are here today. So I'm Helen Ballinger. I'm a clinical commissioning manager at the Integrated Care Board, and I am the ReSPECT lead for Gloucestershire. Over to you, Tanya.
So I'm Tanya Devimon. I'm a consultant in emergency medicine and frailty, and I work at both Cheltenham and Gloucester hospitals.
Emma.
And my name's Emma Husbands. I'm one of the palliative medicine consultants working across the county of Gloucestershire.
Welcome. So today, somebody's in the waiting room, I can see. So should we wait for somebody to come in? Hello, welcome, Jane. So I'm just going to run through quite quickly what is ReSPECT and give a little bit of background to what ReSPECT is in Gloucestershire, and then I'm going to hand over to my expert colleagues here to discuss further about the ReSPECT plan itself and what that might mean for you as a carer and for the person that you're caring for. So ReSPECT stands for Recommended Summary Plan for Emergency Care and Treatment. That's the abbreviation. This is the actual form itself. This is what it looks like. So I'm not going to go into too much detail here because Tanya and Emma, between them, will run through this and talk a little bit more detail about what the form is and how we fill out the form, about the conversation, and what this whole plan means for the individual. So the plan itself is about guidance, and it's about making a decision in one of those emergency situations. So the idea is that you have a discussion with the person first, and you get a feel for what that person's shared understanding and preference and treatment options are. And it has replaced in Gloucestershire our cardiopulmonary resuscitation form that we had, which was called a DNA CPR. So it has replaced that in Gloucestershire, but it isn't just about that conversation. So Tanya will talk more about that in a second. It's a nationally recognised guidance, so it's come from the National Resus Council, and it's being implemented right across the country. It's slow at the moment; not everybody's got it, but the idea is that it's something that you can take with you wherever you go, if you go on holiday and things like that, so that it is recognised. And it's also not just for adults; there is a plan as well for children. So the Children and Young People Services have also got a plan, a ReSPECT plan, and advanced care planning. It came into Gloucestershire in 2019 in October. We were one of the adopter sites, and we agreed to work with the National Resus Council to adopt that as our recommended plan for Gloucestershire, because it has a lot more about treatment options and not just about resuscitation situation. So that's been implemented since then, and it's been rolled out right across the county. So all the other forms that we've had, although if they're in place they're still valid, we are replacing them now with the new ReSPECT plans that are out there. It's about personalised plans as well. So what matters to me is another initiative that's happening in Gloucestershire around personal care and support plans, and your ReSPECT plan is very personal plan to you. It's about what you want, about what matters to you, and this is where we keep it in Gloucestershire at the moment. So this is the personal plan that we've got. This is the orange folder that it's affectionately known as, and in there all of your plans around your care and treatment, me at my best, which is a how I am on a normal day, any other plans that you may have from any other areas that support you to live at home well, and your loved ones to live at home well, then they can sit in this folder and be easily accessible to clinicians and emergency response treatment people. and the ReSPECT plan sits in there as well. And that's what it looks like on the inside. So it's got all of your personal information in there. So you may well come across one of these in the future as well. I'm not going to go into too much detail about that, but just so that you have sight of it and understand that this is another initiative that we're hoping to roll out alongside ReSPECT. Over to you, Tanya.
So what I wanted to do was just talk through a ReSPECT form and what it actually means in practice. Jane, would you mind just going back to the one with the empty ReSPECT form with it side by side, because that's much easier to just talk about. I personally think ReSPECT is much, much better than the previous DNAR or do not attempt CPR forms that we used to have, because these forms are much, much more about living well and what happens to you while you're alive or while a person's alive. As an emergency medicine consultant, I use the information on the forms often for people that I haven't met before, but as a frailty consultant and actually as an emergency department consultant, I quite often fill them in. So the first thing to know is I say the ReSPECT form is a bit like your health passport. So the same as you wouldn't go on holiday without your real passport, you shouldn't be going to health settings without your ReSPECT form. You'd always keep your original passport with you, and you should do the same with the ReSPECT form. That should always stay with the patient, but you'd leave copies all over the place in case it got lost or in case anybody needs to refer to it. So a copy should be held by your GP, by the hospital if you're under the care of the hospital, and also shown to anybody else that matters in somebody's life. So there's no secrets on this, and there's also nothing set in stone. So things can be changed, and as a carer or a patient, you should know exactly what's written on these. It is a patient-held document, which is why these folders we just talked about are so important. It's not about the form, it's about the discussion. So it's an ongoing discussion, and as somebody changes, so should their form. So it's perfectly all right to have things changed, crossed out, or amended on or added to on these forms. And Emma and I often say that we expect these forms by the end of their lives to be a bit dog-eared, have the odd coffee stain on and the odd crossings out, because they do change. They are not a legal document and they can be adjusted. So the things that we normally put on these forms, the first bit that I find important is the bit next to the full name, date of birth and address. Obviously, these are important so we know who we're talking to. But the first bit I look at for a clinician, from a clinician point of view, is what I should call the patient. That is close to my heart because my mother is always known by her middle name. And so I will always look at that. And my dad, who's called Michael, would not respond if you called him Mike, ever. So that's really important to me, particularly if I've got somebody who's maybe not feeling themselves. If I call them by the wrong name, I haven't got a great chance of getting a response from them. The second bit of the document is the shared understanding of my health and current condition. Now, this may well have a list of medical conditions in it, for example, problems with livers or kidneys, high blood pressure, heart disease, dementia, learning difficulties, all sorts of chronic things. But what I find most useful in this section, and you as carers can definitely guide this, is things that give me a better individualized picture of the patient or the person in front of me. So things I find really useful to know there are how often carers go into somebody. I will often write in there maybe if somebody is downstairs living. I will write things like if they rely on a hoist to get out of bed or how they mobilize. I also write if there's family nearby or a long way away. And I'll also write an idea as to whether the person's normally confused or not, because that gives me a really good understanding of where they are compared to normal when I'm meeting them for the first time in an emergency. And from my point of view, it's really important to get a picture of what somebody looks like at their best, but in that tiny little snapshot. I'm sorry, I don't have time in an emergency to read long reams of paper. So give me that snapshot so that this person is differentiated from anybody else that has heart disease or whatever it is, and lets me get an idea of what they're really like. The next box then asks if we've got any other paperwork to refer to, such as advance directives, and then there's a box about whether somebody has a lasting power of attorney or not. So the lasting power of attorney is really important. If somebody can't speak for themselves, it has to be put in place when somebody has capacity, and it just sits in waiting in case somebody loses their capacity. Little side note that ideally anybody over the age of 18 in this country should have a lasting power of attorney. This is not about age. I've had one for the last 15 years at least. It just sits in the bottom drawer of the desk, and it's there if I need it, not because I'm particularly worried about anything. It's more that I don't know what's around the corner, and if I were to have a car accident or bump my head or something and lose capacity, that's the only time my husband's allowed to speak for me. Section 3 is talking. It shows a little box which is meant to illustrate that throughout life we go, all our choices look at what we're prioritizing. And on that scale, in the far left side, they're talking about when prioritizing length of life is the only real priority, no matter how dramatic the action we take for that is. And on the far right hand side is about quality of life rather than length of life. And most people, for most choices in life, fall somewhere in between that scale of just thinking about quantity and just thinking about quality of life. And for most of us, we want a mixture of both. The two boxes underneath there are probably the most important boxes on the entire form. And we ask what the patient values most and what they most fear happening to them. These are boxes that anybody can contribute to and usually give really important information. It will be totally different for each individual, and my priorities in my life will be very different to your priorities in your life. We do see some themes. Things that people often write in those boxes are that they value their friends, their family, they value being at home, they value maintaining their current level of independence. And often we get mention about company for pets and dogs and things like that come up as things that really make people's lives worth living. The things that people fear can often be the reverse of what they value. But again, things that I often hear that people fear happening in their lives are things like becoming a burden. Often people don't want to go into a residential setting, and they fear that, but they often, and I often hear people saying they fear being in hospital or want to avoid being in hospital. More and more I hear them say they want to avoid A&E at all costs because it's not a nice experience for many people at the moment. But anything that scares people or that they want to avoid or they fear happening should be recorded there so we can try and avoid it. The one thing I won't put there is that occasionally people say they fear death. I'm afraid I can't stop people dying. It happens to everybody at some point, and this form is much more about us treating what they fear when we're alive or what they value while we're alive. So these are the things we tend to focus on. Section 4 again talks about what we're prioritizing, whether we're prioritizing extending life or quality of life, and most people fall in the middle with that quality and quantity of life. So living as long as possible, as well as possible, with your own individualized values and things that are important. The bit underneath that asks for the multidisciplinary team to make some clinical recommendations. This is a bit that a doctor or a health professional should be filling in, but it's a good place to give suggestions about what an individual would like to happen to them. Often in this bit, I will write that a lot of my patients would rather be treated at home given the choice, and I will write recommendations and suggestions for how that might be able to occur. For example, giving hints and tips to ambulance people or a GP out of hours that might not know that person in the community normally. It will also give an idea from the multidisciplinary team as to what treatments would and wouldn't be appropriate. But again, this should be in conversation with a patient, individual, or their carers or advocate. I find it very useful as an emergency medicine consultant because I am not a renal consultant or a cardiologist. So having an idea as to what sort of treatments have been discussed in the calm of day can really help me guide my emergency treatment and get the right people involved for more chronic care. The back of the form talks a lot about an individual's capacity and whether they've been involved in the conversation. By definition, the patient or their advocates should always be involved in the conversation. So this is much more about whether the patient has been able to be fully involved because of their capacity. It is very rare I don't involve a patient at all, because people can still tell me exactly what they value in life, even if they can't give me very detailed conversations over these topics. Section 7 is where a consultant or clinician will sign to say they've had the conversation. It's the same as signing any set of notes. You're identifying yourself as the professional that's had something to do with this form. And section 8 is probably the next most important bit. It's a really important bit to me in the emergency setting. And I would encourage you, if you have a ReSPECT form or you know somebody with one, make sure this bit's filled in. It's about the emergency contacts and who to contact in an emergency. People often think that they'll never be away at the wrong time, but it's Murphy's law that the crisis always hits when the person closest to them isn't there. So knowing who to ring and how to get hold of them is really, really important to me. You might think it's always on the hospital notes, but it's really not, and numbers go out of date. So please check they're up to date. The final bit of the form is where people can continue to sign if we update or change anything, or just review the form to make sure that it is still appropriate. And that's talking through the form and the kind of things that we should be doing. The important things are that it's an ongoing discussion. It's not set in stone. Things can change as a patient changes, and that it should be a multidisciplinary or a big team discussion about what goes on to this form, and that includes patients, carers, and various specialties or and disciplines of professional in order to fill in these forms well. Emma, do you have anything to add at that point from what I've said?
I've written notes, Tanya, so I'm going to just pick up on a couple of tiny things. So this is just a very small additional comments in terms of, it's very easy for this to become a conversation about a form, and actually it really isn't a conversation about a form. And if anything, nationally, we're moving into referring to ReSPECT as a plan. This is a plan, and it is an ongoing discussion to be had over time, because exactly as Tanya says, things change, life changes, conditions change, priorities change, and the idea of this being a single point conversation is fundamentally the wrong approach to have to it. I think what is also really important to say is that this isn't about tempting fate. This isn't about being a bad omen. This is about enabling. I want everyone, as Tanya does, to know the things that matter to me. A good cup of tea, being able to communicate with my friends and being independent, all of those things matter the most to me. And that allows a clinician to understand that if I'm involved in an unexpected event or in an accident, how to care for me in a situation where I might not be able to express those priorities. So say them loud and proud, because that way, hopefully, the way that your life is lived will be with those priorities for you at the very heart of it. And fundamentally, none of us know what's around the corner. That's one of the real challenges. And so the really big key bit of this form is, and plan, is section 3. Actually, it's about what matters to you. We can write lots of recommendations around certain clinical elements, but we might not cover the thing that happens. And so whilst that has a role and is very important and is part of it, particularly with certain conditions, it absolutely isn't the fundamental be all and end all. And just the last bit that I was going to say is that lasting power of attorney does have two strands. So there is a lasting power of attorney for finance, and there is also a lasting power of attorney for health and welfare. If somebody holds lasting power of attorney for finance, they have no more say in any conversations around your health than the next person. But if they hold lasting power of attorney for health and welfare, effectively what they become is a surrogate you in a moment where you're unable to speak or to express your views. So it's just an element of different types of lasting power of attorney having a different role. So that was the only other thing I was going to highlight.
Thanks, Emma.
Has anybody got any questions before we move on? We didn't really touch on the resuscitation part on the bottom bit of the form, which I don't know whether Emma or Tanya want to come in on that bit, because that's the bit that tends to be a focus for everybody. And as you said, it's not the focus anymore. We're moving away from that, but it is part of the discussion.
A recommendation around resuscitation is included within this form, and it really is one of those components of a discussion. I'm sure Tanya will experience this as well, that the perceptions around cardiopulmonary resuscitation, which is this very specific part of an attempt of resuscitation in the situation, particularly of advancing illness, is one that we know has a very, very tiny chance of being successful. And the phrase being successful, even within that, there is a nuance, because we know that success is measured on, statistically, success is measured in terms of being discharged from hospital alive. Being alive does not necessarily mean that you are in the same state that you were prior to an attempt at resuscitation. So there are lots of components to the concept of CPR particularly, and what so matters in these conversations is that element of how you want to live your life. The reality, as I say, in terms of advancing illness and advancing age, because we're all going to get older as much as we're all at some point going to die, is that resuscitation attempts, cardiopulmonary resuscitation attempts, may well have a far smaller chance of working. And it's really about those interventions probably that have reversibility, such as an infection being treated or a blood clot being treated, and all of those events that happen before somebody's heart stops, that are the most important to discuss in these situations. We know that from a media perspective, television programs and films give us a terrible concept of how successful CPR is in reality. And this is why having these conversations in a very open and honest way is so very important, because it's understanding what an intervention like that is likely to achieve, has the chance of achieving, and the reasons why that as a very final intervention may well not be the right thing for an individual, because we will have tried all of those other things prior to that, if that is somebody's priority. And Tanya, you've probably got a better explanation for that given your work setting.
So it wasn't an accident that I skipped over that. I really think the conversation and knowing what someone values or doesn't is more important. CPR, jumping up and down on somebody's chest and breaking their ribs, is a very specific treatment for a very specific condition. And it's become, I think people think it is thanks to media and television programs, people almost believe it'll cure anything. But the same way as insulin is a very specific treatment for diabetes, or dialysis is a very specific treatment for renal failure, CPR is normally a very specific treatment where the only thing that has happened is something very specific has gone wrong in the heart. And I think the common misconception is that if you are not for CPR, you are not for any treatment, and that is totally wrong, and we need to dispel that myth. And it is far more important that people get the intravenous antibiotics or the antibiotics, the other medications, the oxygen, the fluids, the physiotherapy, the great nursing care. And if all of those great treatments fail and someone continues to deteriorate to the extent that they're going to die, then CPR will make no difference at all to those people, and it's the wrong treatment at that time. So from my point of view, we have CPR on the form very specifically because of public perceptions, and there's so many other treatments for that and other conditions that we don't mention. And I understand why it's there, but I look much more at all the other information on the form, and that's what I'm bothered about writing down, because it changes how I manage people in an emergency as well.
I can totally agree with what you've both said there, and thank you for clarifying that. I'd like to share a personal experience with my father-in-law recently, who the only thing he focused on was that he wanted CPR. And we had a long discussion about lots of different things and how actually that wouldn't make any difference really to his overall condition. He's an insulin dependent diabetic. He's had a heart attack. He's got a heart stent. He's got hydrocephalus. He's got all sorts of other things going on. And was recently told by the consultant that he could have all these other different treatments. And when we got in the car, he just said to me, "I just want to be allowed to die naturally." And I said, "Good. I'm glad that we finally, after all of this discussion, got to that end point, because actually, because you want to die naturally doesn't mean to say we won't treat you for your insulin or if you have an infection or anything else that is treatable and will give you still a good quality of life and help you to live your best life." And with that, we've done a really good ReSPECT plan with him now, but it took him a long time to get to that way of thinking, because he was only looking at this plan as being whether his heart stopped or not, and was convinced that he wanted somebody to resuscitate his heart. But after months of talking to him, we've now had a long discussion, and he's began to realise that actually he just wants to be allowed to die naturally. He's 81 and he's quite prepared now to let that happen, and we've written it all on a plan for him, what he wants. So I think that just reflects really about how important that discussion is to help people understand and come to terms with it themselves, really, about what they want as well.
And if I can add a little bit to that, Helen, I think the other thing that's really key about CPR, and you'll see this in terms of the document, is that it highlights attempts. And CPR is never a binary action. It isn't a case of if you have it, it will work, and if you don't have it, obviously it won't work. It's actually about an attempt, and attempting may not work, and just as much as the concept that it would. And I think often when I'm having conversations with people, when you reflect back that I want an attempt at I want to be resuscitated. It's not even I want an attempt at resuscitation often. Actually, that's about somebody saying that they want all appropriate things to be tried or to be considered and tried. So it's that sense that if you aren't offered resuscitation, we will be letting you die. That's not quite the same thing. And I think it's being able to help people understand that when we're talking about those different interventions, it is the things that are likely to give them the best outcome. And that's really, really key in those conversations. And for me, one of the words when I'm having that discussion, attempt, is so important, because it is only ever an attempt.
Can I just also add that both Emma and Helen have touched on this. Talking about it doesn't make it happen. And I think what you've said, Helen, about your dad is very true for my dad, except my dad is in a very different health position to yours. So he is coming up to 80, but he is extremely fit and cycles a huge distance, but he is on a daily basis and, you know, terrifies me with his level of fitness. But for a good few years now, my dad has learnt that this conversation pops up from time to time as to what matters to him and what his priorities are. And he now knows if he comes to dinner at my house, we'll have a quick chat about what matters to him and what his values are before we have dinner. And whereas at the beginning of that process, if I ever said, well, you know, Dad, if you ever got really ill, what would matter to you? He would just originally go, nope, not going to talk about it. I'm not going to talk about it. We've got past that now. And it's gone from being a taboo subject to being a bit of a joke where he'll walk through the door and go, it's still about the cricket. I need to enjoy my cricket, whatever you do to me. Now can I lay the table? And once it becomes a normal conversation and all that fear is taken away from it, it's actually a really positive conversation. And it means that I know with absolute clarity, if my dad ever can't talk for himself, I have a true idea of what he would be saying if he could, whereas before it was just a shut down subject. So, and a lot of people I have these conversations with, because a lot of the people I talk to have very long-term conditions, they're extremely old and probably differ in Emma's population in some ways, but a lot of people find this a really therapeutic process to have the opportunity to say what matters to them and get that conversation done, open, out in the open. And then it's almost like if you've got something that's continuously going round in your mind that you're worried you'll forget, writing it down can help. So having that full and frank conversation can take a lot of the stress out of things for people, and we don't have to continue to come back to it again and again and again. We can just come back to the important things if something changes.
That's brilliant. And I think also because today's session is for carers, that it's really crucial that the people as carers equally have that conversation as well and express their wishes and have their plan written up as well, because you never know when their plan might need to be in action. So it's equally important for all of us, actually, not just carers, but all of us to have a plan in place about our future wishes. Shall I move on and see what I've lost track of the slides now because we went backwards, so I might have to go skip over a few again now. So we've done that, and the orange folder where it can sit. We'll move over the form. We've done the form.
Lovely.
So before I move on, has anybody got any questions about this? Or shall I show Joe's ReSPECT journey? Okay, I'll show Joe's ReSPECT. I think I might have to stop. It might show actually if I click on it. Let's see. Are we showing?
In emergency situations, people are not always able to make or express choices for their treatment.
Helen, you'll need to close the slides and reshare, I think.
Receiving treatment they didn't want.
Hold on.
Even if the healthcare professionals thought it was in their best interest.
This is where help
ReSPECT helps to change that.
1 second. Can you hear it?
ReSPECT is a form that clinicians can use to record a
Could you hear it?
Yeah, we can hear it, but can't see it at the moment.
Right, let me stop sharing and then I can reshare. Okay. I know on Teams you have to press like a you have to get the microphone working. Right.
On this one, if you
situations.
Oh, there you go.
Is that working now?
Yeah.
Yes.
Yeah.
Okay, I'll make it bigger then if that's working. Thank you.
In emergency situations, people are not always able to make or express choices for their treatment. That means they may end up receiving treatment they didn't want, even if the healthcare professionals thought it was in their best interest. ReSPECT helps to change that. ReSPECT is a form.
Sorry,
that clinicians can use to record a person's preference for clinical care in the event of a future emergency. But it's much more than a form. It's about the conversations people have and the decisions they make in order to be better prepared. ReSPECT is available to everybody, but is particularly relevant for those people who have a long-term condition that will deteriorate over time, and for those who are elderly or frail. Let's talk about Joe. Joe has a progressive lung condition. He is visiting his GP following a recent admission to the hospital with an infective exacerbation of his condition. This was his third admission over the course of the past year. His GP asks Joe how he has been and gently explores his experience of being in hospital. She asks Joe whether he has thought about what he would want to happen in the event of an emergency happening again, and how Joe would feel about being readmitted to the hospital. They begin to discuss it further, using the ReSPECT form. Over several weeks, Joe, his family, and his carers have a number of conversations with his GP and with his respiratory consultant at his outpatient appointment. Collectively, they discuss Joe's condition and which treatments he would and wouldn't be prepared to receive. When Joe is happy with the decisions he has made, his ReSPECT form is checked and signed by his GP. Joe keeps the form in a folder where he stores all his important information about his health and well-being and what his preferences are in an emergency. This is kept in a safe place where his family, friends, carers, and neighbours can find it, and it is easily recognisable to emergency services. The presence of the document is flagged on his GP's computer system. A few months later, Joe's breathing rapidly deteriorates again, and he becomes very ill. His neighbour calls for an ambulance. The paramedic arrives and asks and checks with the neighbour if Joe has any care guidance, such as a ReSPECT form, and then checks what is documented. The paramedic uses the information to help them more easily decide on the best course of action for Joe's treatment, as Joe is struggling to speak. Joe is admitted to the hospital, and the doctor in ED asks to see his ReSPECT form and checks to see what the clinical recommendations are to guide appropriate care for Joe. He recovers from his infection, but on discharge is more frail. Before he is discharged home, the ward doctors talk to him about what Joe's thoughts are over future care in an emergency. They discuss Joe's stay and explain that he didn't tolerate a strong breathing machine during this admission. Joe agrees that he wouldn't want to try this again. Joe feels that he would prefer to be cared for at home and avoid hospital again if he can. But he asks about antibiotics. The ward doctor explains about antibiotics in the community and that this is sensible to consider. Joe's GP visits him at home after his discharge with his family. They review his preferences about his options for care. They both agree with the plan to focus on care at home. She explains about a team who can give antibiotics, even through a vein, in the community, and documents on his ReSPECT form that this is a reasonable consideration. The GP takes a photo of Joe's form, which will be securely transferred to his medical records. Joe has a further 2 episodes of infection at home, and the teams in and out of hours are able to arrange for appropriate community treatment. He becomes increasingly frail and decides to go to a residential care home. In the home, they ask and check that Joe has a ReSPECT form and are pleased to see that this has come with him. This is again reviewed with Joe, who states that he no longer wants to have infections actively managed, but would like to have medicines to keep his breathing comfortable and to die peacefully. The care home staff, alongside Joe's GP, talk to Joe about the little things that matter to him. Time with his family, watching the rugby, and a tot of whiskey every night. Joe's GP updates his ReSPECT form to reflect his changing wishes and uploads this to his electronic patient record. When Joe becomes ill again, the care home staff contact the GP and district nurses directly, who visit to review his condition in line with his ReSPECT guidance. They are able to diagnose that Joe is dying, and with the staff maintain his comfort, and he dies peacefully in comfortable surroundings with his family by his side. The ReSPECT process puts people and those important to them at the heart of the decision-making process, enabling them to be involved in planning their own care so that their wishes are known and respected. The guidance can relate to both interventions that would and wouldn't be recommended for that person. It is a form used across all care settings and should be amended over time as people's wishes and circumstances change. Always remember to ask and check if the person has a ReSPECT form. If not, start your ReSPECT conversations now, review regularly, and share across your healthcare system.
Stop sharing that now. So just to summarise, the key points of today's session is that ReSPECT is an emergency and treatment care plan. It's guidance, it's not legally binding. It's there to support best interest decision making and personalised care, so making sure that it's really personal to you. It's not just about CPR attempt recommendations, it's a lot more than that, as we've already gone through. The form or the plan must go with you, stay with you wherever you go. So if you go into hospital or into a care home, as we saw in Joe's story, take it with you. It's really vital that you've got your information so that you can share that information with others. And if you're not sure whether somebody has any ReSPECT guidance available, always remember to ask and check. And that's really crucial. And that's it really, I think, from all of us. So thank you to Tanya and Emma, our experts in the room on ReSPECT and out there having the conversations, and to Lorna for organising the session and inviting us along. Thank you.
Thank you all.